Good morning, everybody. Hopefully you're all starting to come through. Sorry about the delay, we was just having a little bit of technical issues, but hopefully you can see our first presentation. So we're really grateful today. We have a host of professionals that have come to do a talk for us around paediatric asthma. So we've got Dr. Yanney, who's one of the paediatric consultants at Sherwood Forest. We've got Dr. Bhatt, who is one of the respiratory paediatric consultants at NUH. Then we've got Debra Forster, one of the paediatric specialist nurses at NUH. We've got Anneka, one of the pharmacists from NUH. I think your speciality is paediatric asthma as well, isn't it, Anneka? Sorry. And then we've got Kay Massingham, who's coming to do a talk around vaping in children across Nottingham. I'm so sorry, Kay, I didn't ask where you was from before. I do apologise. So I do apologise.
I'm from Nottinghamshire County Council's Public Health team. Lovely,
thank you. Sorry, Kay. That's my fault. Obviously, there's different sections that we're going to go from one to the other. We will do questions at the end of each section. You're welcome to put them in the chat, but obviously none of them will be answered until the speaker has spoken. I will hand over now to Dr. Yanney so we can get started. And Dr. Yanney, just let me know when you want me to move on to the next slide. Thank you.
All right. Yeah, thank you very much for the invitation, and apologies, it was all my fault for the hold up. I couldn't quite get my slides to share, but I'm pleased to be with you, and I'm going to sort of lead off basically talking about diagnosing asthma in children. Next slide, please. What I'm hoping to do is to just give you a bit of an update about a pilot that has just completed. We've just run it for 12 months, and it was basically a pilot of diagnosing children with asthma in the community, and trying to sort of get a model that might work for the long term. So we've had funding for a year, which has now just come to an end, but I'll give you some of the results on the next slide of what we found. I'll also cover the very recent BTS and NICE guidance that came out in November, which has got some really helpful information about diagnostic tests in children with asthma, what to do, when, and what order to do them, and that sort of thing. So I'll talk through that. And then I'm also hoping to talk through 3 cases, if I've got enough time to get through all 3, which I think highlight why diagnostic tests have a place in the management and how they help. Okay, next slide, please. So yeah, this first slide is just to run through what we found with the pilot project. It's not quite finished. So it started in February last year, and it has run for a complete 12-month period. But there are a few children who've been referred who haven't yet been seen, who are hopefully going to be seen over the next few weeks. But everyone who's already into the system will be seen now. So hopefully by the time it wraps up completely, we'll have seen just over 400 children. And out of the 400, out of the 325 who we'd seen by the end of January, we managed to confirm a diagnosis of asthma in a bit less than half of them with spirometry or pheno. There were another 30 odd who had a very convincing history and responded well to treatment. So even though their lung function didn't confirm asthma, the history and response to treatment was sufficient for us to be able to say we felt, you know, these children were quite likely to have asthma. So what that comes to is about just over half of the children who we saw, we were either able to confirm confidently or make a reasonable clinical diagnosis, and that leaves, you know, just under half who we couldn't make a diagnosis. And the reasons for that were often because children were on regular treatment and had no symptoms, but because they were on treatment, we couldn't be sure that the reason they had no symptoms was because of the treatment they were on, or was it because they didn't have asthma or no longer had asthma. So when I talk a bit more about the BTS guidance, it's recognised that what we found in our pilot pretty much mirrors what the guidance estimates might happen if we're testing all children with asthma, that about 50% may not be diagnosable with the tests. And so there is some thinking that needs to happen about how we manage that group of children. It's worth saying, and that's probably not easy to sort of highlight at this point here, but there were definitely some children who we were able to confidently exclude a diagnosis of asthma, and usually these were children who weren't on any treatment and didn't have symptoms. So there weren't as many of those for us to be confident about saying they didn't have asthma, but the last time we looked at that was back in October, so I don't have the figures for the complete 12 months, but it feels like maybe about 8% of children might be in that category. So these were children who at some point may have had a possible diagnosis of asthma, but at the time that we saw them, they were off treatment and had no symptoms. So there are some where we can rule it out with normal spirometry. Next slide, please. So I think the place to start when we're trying to diagnose asthma is clearly the history and examination findings. And that's really important that we get that information accurately. And what we're looking for a child with asthma is a combination of the symptoms that you can see on the screen. So cough, wheeze, and breathlessness. Sometimes the symptoms might be described as chest tightness, and sometimes people use different words to describe wheeze. But wheeze can also be a bit of a minefield. You know, people can often use the word wheeze to mean any sort of noisy breathing, and certainly in my practice, I do try and make a distinction between rattles or ruttles and wheeze. Ruttles is where it sounds like there are secretions in the airway that they need to cough up, and that is sometimes described by parents as wheeze, but it's important to make that distinction. But what you're really looking for is a combination of those three. So if you see a child who just has cough, but no breathlessness and no wheeze, I would be wary about making a diagnosis of asthma. It doesn't mean you shouldn't think about it, but it's rare that you would have asthma with only one of those symptoms. Next slide, please. So I'm not expecting you to read this slide, but really just to highlight that there is a lot of variation in how asthma is diagnosed. So this is the slide from a publication by Professor Turner and his team, looking at all the different guidelines that were available at the time and summarizing the recommendations for how you might make a diagnosis of asthma in children using diagnostic tests. I can't read the slide from here, so I'm not expecting you to, but it's fair to say that, you know, there isn't complete agreement, or there wasn't until we had the new BTS guidance come through. But on the next slide, I've listed some of the points. So yeah, there are a number of different criteria that can be used to diagnose asthma. The first one is showing some degree of airflow obstruction. So an FEV1 less than 80% is one of the factors that is considered key. A FEV1 FVC ratio of less than 80%, or a bronchodilator responsiveness measure of 12%. So what we mean by that is baseline spirometry increasing by 12% or more after salbutamol. And that's probably the most specific of the tests, the most specific finding in terms of it's the most accurate, but it's not necessarily the most sensitive way of picking up asthma. And then you'll see for pheno, exhaled nitric oxide, that there are a number of different cutoffs that have been looked at, and each one has a different specificity and sensitivity for picking up asthma. So although I'm showing you those numbers, I'd like you to, certainly for the pheno, to just remember what's on the next slide. Could you move to the next slide, please? Oh, sorry, it will be coming up. It's on the. I'd like you to remember the BTS, the new BTS guidance, just for simplicity, and they have a cutoff of 35. But we'll talk through that in a bit more detail in a couple of slides. I've got here, just because we were talking about history, some of the things that are worth looking out for, which are confounding symptoms that may be an indication of an alternative diagnosis to asthma. So children with a wet cough, or problems with vomiting and coughing associated with vomiting, and any of the sort of clinical signs that you can see listed on the left-hand side, so finger clubbing, other sort of chest deformities. Just beware that there are other conditions that quite often are confused for asthma, and cystic fibrosis isn't common, but at least I've seen at least 2 children in the last 10 years, maybe, who their diagnosis of CF was made late, so it was at around 5 years of age, and in both of those they would have had a diagnosis of asthma and treated for asthma for many years. But yeah, so it's worth being aware of the sort of red flags, and the wet cough, which is persistent, is one of them. That is also a common symptom of protracted bacterial bronchitis, which I hope you're all aware of now. That's similar symptoms to what you would see in a child with CF, except it doesn't have an underlying a chronic underlying cause for it, but it does often need active treatment in much the same way. Next slide, please. So the new BTS guidance has 2 categories for how to make a diagnosis in children, and for the under 5s, it's not possible to do the typical diagnostic tests that we've looked at. And in these children, the main way that you will make a diagnosis of asthma is to give them a treatment trial. So what the guidance recommends is that you give them an inhaled corticosteroid for 8 to 12 weeks, and that's generally beclomethasone, 50 micrograms, 2 puffs twice a day, especially in that age group. You would start at that sort of lowest dose and review after 8 to 12 weeks. And if their symptoms are better, you can stop and see if their symptoms return. If their symptoms are not better, then you just check that they've been doing it correctly, and all the sort of other things that need review, other triggers. If they don't improve despite sort of reviewing all the things that you need to look at, then just refer them through for a specialist opinion. So I think the guidance is encouraging us to try and get a specialist opinion for children early, rather than persist with higher and higher doses of inhaled corticosteroids in children who either may not have asthma or certainly who don't seem to be responding for whatever reason. So the treatment trial is really important, and I've listed it here as for children under 5, but there will be children over 5 who can't do diagnostic tests, and the same will apply to that group as well. Okay, next slide, please. So this is the slide that I was referring to earlier about the cutoff to remember. I think this is a really helpful summary of the sort of process of diagnostic testing. It's made it so much simpler, and the idea is that you, if you've got access to pheno, then you can make a diagnosis of asthma if a child with a consistent history has a pheno level greater than 35. So you don't then need to progress to do any further tests if you've got the right history and you've got a result in that ballpark. You can make your diagnosis, and that's the diagnosis confirmed. If the pheno is less than 35 or they're unable to do pheno, then you move on to do spirometry, and the best spirometry indicator is the bronchodilator responsiveness. As I mentioned before, it's very specific. So if it's positive, if you get with a good technique, you've got more than 12%, then you can make a confirmed diagnosis of asthma. There is a caveat of a lower percentage change. So if their baseline FEV1 is 100%, so their starting point is basically at their predicted, then you only need a 10% change to confirm a diagnosis of asthma. So with those two tests, you generally will capture most of most children with asthma, and certainly in our pilots, that's what we've been doing. It does provide an option to do peak flow variability in children where access to spirometry is not available, but there is, a lot of the sort of concern about the peak flow variability is it's not as good as a spirometry test, so it's not in that process as an add-on to spirometry. It's there more for if you just can't get access to spirometry. So if you've got pheno and you've done spirometry and you've still not got the answer, then I would be looking at the step after, which is to do a total IgE, check blood, or check blood to see eosinophils. I've got my tongue in a twist there, or skin prick tests. So either of those, any degree of sensitization to aeroallergens, particularly house dust mite, would be additional evidence to say that a child has asthma. So one of the cases I'll come to highlights this quite nicely. All right, next slide, please. So in the next 5-10 minutes, I'll try and whiz through these few cases. So this first child I saw about 18 months ago, just before we started the pilot, and I just thought he was a great example of why diagnostic tests may be helpful. So he had viral wheeze until he was 5, but for 3 years was apparently symptom-free until the November before the February before I saw him, where he had a hospital admission and had quite a severe exacerbation. So I've put down that he had oxygen and IV magnesium sulfate as basically a way of saying he had severe, possibly life-threatening asthma, certainly severe. And he had 2 further ED attendances after that. And I think on maybe the second ED attendance, he was appropriately offered treatment with an inhaled corticosteroid. But surprisingly, parents didn't want to give it because they didn't feel he had asthma, or they were worried about the side effects of inhaled steroids. And what they did instead was basically just to carry on using salbutamol. So there was a bit of a, sorry, next slide, please. There was a bit of a failure in his follow-up. So there was a plan for him to be seen for 2 months after his hospital admission, but for whatever reason that didn't happen. And the key thing that made parents think he didn't have asthma was because he had good exercise tolerance. And that does seem to come up with parents quite a lot, that they don't believe their child has asthma if they can manage exercise without a problem. But I want you to just keep note of the fact that this child came in, needed oxygen, needed IV magnesium sulfate, had a severe attack and came to A&E a couple of times. And I think that's the message that I want to convey here, is that's probably more important than the exercise symptoms that most parents it may not be most parents, but some parents believe is more needed for a diagnosis of asthma. Is the severity of the attacks needs to be given a lot more weight. Next slide, please. So we did some tests. In fact, I saw him in a clinic when I didn't have our specialist nurses available. So I did the pheno on my own, and I'm mentioning that just because I'm just trying to make it just highlight that it is an accessible test, that if you've got the skills to do it, you can do it relatively easily. But with that result, it was clear cut to me that he had asthma. And so next slide, please. I said to his mum, he has got asthma and he needs treatment. And once we had that discussion, she was able to agree to take the regular inhaled corticosteroids. I went for Symbicort at this stage. He'd been off a Clenil before and obviously hadn't taken it, but I felt that maybe he would adhere better to a treatment like Symbicort, which he could also use in line with MART regime. We went through inhaler technique. We gave him a written plan. I did make a plan to do his spirometry, and bearing in mind this is before the new guidance came out. Next slide, please. And also it's sort of my practice, but the pheno had responded really well. So he felt a significant improvement in himself. And as you can see, his spirometry didn't add anything at this stage. He'd already, well, I guess once he'd started treatment, we didn't demonstrate any airflow obstruction. There was no bronchodilator responsiveness, but he clearly has asthma. We've shown that with the response to pheno. We've shown that with the symptom response. But because he's now on treatment, the spirometry is normal. So I think this case also highlights, several aspects of how the tests are limited. But the key to this child was getting a pheno before he was on inhaled corticosteroids, because we got the answer there and then. Next slide, please. This second case is a little bit more complicated. I'll try and run through it quickly, but he's a 10-year-old boy who was referred to one of my clinics with urticaria, and the description was that he had it for years, so nearly 9 years, from 6 months of age. I don't see many children that young who get spontaneous urticaria, but there was a very clear history that whenever he goes swimming, he comes out in urticaria. But I think the thing that had really concerned parents was he'd had an episode of anaphylaxis on New Year's Day, and it wasn't clear what had caused it. So he started off with swollen eyes, generalized urticaria, real difficulty breathing. And next slide, please. I think was, needed hospital care. In the background, he has had wheezy episodes with colds on and off, but again, no significant exercise symptoms, no nocturnal cough. I think his mum is a healthcare professional, so very clued up and knows, good knowledge, but was convinced he didn't have asthma. Just needed to understand why he'd had such a severe attack that day. Next slide, please. So when I examined him, he had scattered wheeze. He also had a wet cough. So we tried pheno. It wasn't successful on the day. I'll show you the spirometry results as well. But because he was referred to an allergy clinic with unexplained anaphylaxis and urticaria, we did do some skin tests. I did a chest X-ray, which was normal partly because of the wet cough. And I'm giving you results that not in the time that we had them, because the cough swab result came back a few days later. So I didn't know that at the time I saw him, but I'll come back to that in a second. Next slide, please. So this was his spirometry, and as you can see, he has got quite significant airflow restriction. So 63% predicted was his FEV1. And following salbutamol, there was a 11% change. So he didn't reach the 12% threshold, but because his baseline was low, I felt that I had enough evidence to say he did have asthma. So I couldn't get a pheno, but his spirometry was borderline, and I felt there was more than enough evidence to say that he had asthma. Next slide, please. And we did do skin testing because he'd come for that reason, and he's got quite a strongly positive house dust mite. He's strongly sensitized to house dust mite. So in the algorithm of tests, he would fit with a diagnosis of asthma because he's now got that sensitization. But what was interesting was he had peanut allergy, which was not known, and that episode on New Year's Day was because he'd handled traces of peanut. He'd had an anaphylactic reaction, probably because he had this allergy, didn't know about it, also had asthma, which wasn't treated, and therefore had a severe episode. And so it just highlighted the importance of getting that diagnosis spotted and treated to prevent future significant risk. Next slide, please. So we ended up with multiple diagnoses following that appointment. We confirmed peanut allergy, diagnosed asthma. I felt some of his urticaria was due to acute spontaneous urticaria, but the sort of swimming type reactions I thought were due to a physical urticaria. There was a bit of the history that sounded like contact allergy. And the other bits to mention was the wet cough, and the fact that we got Staph aureus on his cough swab meant that he also had bacterial bronchitis. So yeah, a bit of a mixed bag. It's just to sort of highlight that there can be several interacting things to be considering in a child with symptoms of asthma, and teasing them out is really important. I did have one other case, but I think in the interest of time, I will skip over that and yeah, I think I'll finish there. Thank you for your attention.
Thank you very much, Dr. Yanney. Does anybody have any questions for him at all? Somebody's just put in the chat, what are the levels of eosinophils to be looking for with children?
Sorry, yeah, I think anything over 0.5, and it does need to, we need to bear in mind that for different ages it will vary. So 0.5 is a sort of general rule of thumb, but Dr. Bhatt, you might be able to help me out with that one.
Yeah, I think look at the range that your lab provides you, and you're looking for about that upper end of normal for your lab, because I think labs, and so it is lab and age dependent. There could be in a slightly different counts provided by your lab. So that's what you need to look at. So whenever you get it done, you will always get a normal range provided. So if it's above the upper range of normal, then it's high. That's how we should look at it. I think for purposes of starting treatment with biologicals, there are cutoffs, and the higher the eosinophil count, the better is the response. And 300, 500, you can look at those things. But as a guidance for diagnosing, I think what even the B test is saying is that above the upper end of normal for your lab's range.
Thank you. Somebody else put about starting a steroid for children under 1, but I think we've got Anneka, one of the pharmacists, who'll be talking about medication, so more than likely that should be covered by Anneka or Debra. And somebody's just asked about the slides. I think, are you all happy to share the slides afterwards? I think we said we were.
Yes. Yeah. But I think that the short answer to that previous question is no, generally under 1. So I think, you're not entertaining a diagnosis of asthma for somebody under 1. So generally no, but I think that there might be individual exceptions which you might want to refer on for to be considered.
Okay, thank you. So yes, all slides we will share at the end. And what I'll do though is I will hand over. Is it Debra or Anneka first?
Yeah, sorry, we were just uploading our slides. It'll be myself first.
Lovely. Just to confirm, we can see your slides fine.
Perfect. Great.
Thank you.
In that case, I'll get cracking. So my name's Anneka, and I'm the Children's Respiratory Pharmacist based at QMC in Nottingham. Most of my role does focus on managing patients with cystic fibrosis, but I do look after all aspects of respiratory care. And I've also got Debra here with me.
Hello, I'm Debra Forster. I'm a children's respiratory and community nurse based at Nottingham Children's Hospital, and I work with the team as well.
So essentially, the topics that are going to be covered today will be drug pharmacology. So I'm essentially going to take it back to basics and deliver a bit of a science lesson. So I'll talk about our inhaled therapies, our oral therapies, and some of our injectable therapies. I'll briefly mention MART licensing, and then I'll hand over to Debra, who will talk about asthma action plans and leave you with some food for thought with a really interesting case study. So if we start off with salbutamol, can you see my mouse hovering?
Yes, we can.
Great. So we've got a beta adrenoreceptor, and this is a cell membrane specific receptor. The two that I'm going to talk about today are the beta-1 adrenoreceptors, which are cardiac related, and you've got the beta-2 adrenoreceptors, which are found in the lungs and other cell membranes. Salbutamol itself is recognised as a beta-2 agonist receptor, but it will also work on cardiac beta-1 receptors. So if we take this to a cellular level, salbutamol will bind to this beta-2 receptor, and then this in turn will activate a G protein. This then activates adenylate cyclase, which in turn will increase the production of cyclic AMP. This then leads to a block of calcium release from intracellular stores, and then this leads on to smooth muscle relaxation and hence bronchodilation, which is the desired effect of such agents as salbutamol. And then very simplistically, it's the activation of your beta-1 adrenoreceptors that can lead to some of the unwanted salbutamol side effects, such as tachycardia. If we step things up now and look at inhaled corticosteroids, so again, at a cellular level, corticosteroids will reduce the number of inflammatory cells in asthmatic airways, including eosinophils, T lymphocytes, mast cells, and dendritic cells. Epithelial cells themselves are a major target for inhaled corticosteroids, and this is because many activated inflammatory genes will be turned off in airway epithelial cells. And it's thought that when inhaled corticosteroids, oh, sorry.
I see the cursor.
Was there a note about people not being able to see slides?
I think it's just one attendee who's not been able to, everybody else can see them. So I've just suggested logging in and coming back again, and obviously reassured that we will share all the slides, but everybody else can see them fine.
Fab. I'll continue. It's thought that there'll be a significant reduction in eosinophils in as little as 6 hours when you start using an inhaled corticosteroids, and longer term, you'll start to see reversal of airway hyperresponsiveness, probably as a direct result of structural recovery of structural damage within the airways that's been caused by asthma. This is why the evidence will often suggest, and obviously Dr. Yanney mentioned it also in his presentation, that if you are starting inhaled corticosteroids, we would suggest a review, probably 8 to 12 weeks after starting this, just so we can see if there has been any benefit and any reversal of structural damage. If we step things up again and look at our inhaled corticosteroids in combination with a long-acting beta agonist, so this is where it starts to get quite clever. So corticosteroids themselves will increase gene transcription of beta-2 receptors, which will result in an increased expression of these cell surface receptors. We've seen this demonstrated in both in vivo and in vitro studies after application of a corticosteroid. Long term, this means that corticosteroids will actually protect against the downregulation of beta-2 receptors, which is something you would generally commonly see if you use salbutamol on its own as an agent. Corticosteroids will also enhance the coupling and hence the activation of G proteins where beta-2 adrenoreceptors are activated. So again, you're enhancing the beta-2 agonist effects. There is some evidence as well to suggest that beta-2 agonists will enhance the anti-inflammatory effects of corticosteroids by having some action on glucocorticoid receptors. So hopefully this starts to build an argument as to why MART therapy, which obviously combines both your inhaled corticosteroids and your long-acting beta agonist, can be a huge benefit for some patients just because of how these two agents work together really well. So if I move away from our inhaled agents and we'll move on to the first of our oral agents. So montelukast will bind with high affinity to the cystenyl leukotriene receptor. There are various leukotrienes involved in asthma and they'll be excreted from various cells and will contribute to the inflammatory processes that you'll often see in asthma and allergic rhinitis symptoms. Leukotriene receptors themselves are found in airway cells. And when montelukast binds to leukotriene receptors, you'll get inhibition of the leukotriene physiological effects. In asthma specifically, it's thought that low-dose montelukast, and by this I mean 5 milligrams, can actually induce significant inhibition of bronchoconstriction that's caused by leukotriene D4. Now, the pharmacist in me couldn't talk about montelukast without mentioning the drug safety update that was issued by the MHRA. This was initially brought to our attention back in September 2019, but there was another update last year. And essentially, this drug safety update was advising all healthcare professionals to be alert to the effects of montelukast, such as sleep disturbances, mood and behaviour changes, and sadly, at the extreme end of the spectrum, suicidal ideation. The most frequent adverse effects that have actually been reported are nightmares and night terrors. In terms of trying to understand the mechanism of action for these potential neuropsychiatric effects, it's not actually fully understood. There have been lots of potential hypotheses, and there was an in vitro study that was done back in 2022, and they hypothesized that there's a montelukast metabolite that can form a conjugate with glutathione, and then very simplistically, it's thought that by altering the levels of glutathione in the brain is what may lead to these neuropsychiatric effects. It's also worth noting that not all asthmatic patients will actually see benefit once they've started montelukast, and this is thought to be down to genetic variation. I'll just mention it as an aside, but obviously pharmacogenomics will probably be a very powerful tool in the future in determining and tailoring treatments for patients. With Montelukast, it's probably useful to review our patients within 4 to 8 weeks of starting them on this. Sooner, obviously, if they do start to experience any of the adverse effects, just because if they're not seeing any benefit, then it is probably an agent that should be stopped. So to complete the cycle, I'm going to talk about treatments that are often either recommended or initiated in secondary care. So we will continue with our oral agents. Theophylline is a competitive, non-selective phosphodiesterase inhibitor that will work to increase the concentrations of cyclic AMP. And so similar to our beta agonists, this will relax smooth muscle and lead to the desired bronchodilation. Theophylline itself also exerts an anti-inflammatory effect by switching off activated inflammatory genes. Interestingly, it's thought that the anti-inflammatory effects of theophylline in asthma will occur at lower plasma concentrations than are needed for bronchodilation. Practically, we don't actually have much usage of theophylline in our patients. This is for several reasons. One of which is that it is a drug itself with a narrow therapeutic window, and so drug monitoring is required. When I was back at university, I was always taught that theophylline's classed as a dirty drug, in that it has several drug interactions, so it's always good to check for these if you're either starting or changing doses of other drugs. The most common side effects that you'll typically see with theophylline are down to the phosphodiesterase inhibition and will include nausea, vomiting, headache, and possibly GI reflux. Theophylline is also a non-selective adenosine receptor antagonist, which is what can lead to some of the unwanted cardiac side effects that we may see. In terms of product availability, there are only 2 on the market now. So we've got Unifilin Continus tablets, which are prolonged release, and there is an unlicensed liquid. Theophylline has an AMBER 2 classification on the Nottinghamshire formulary, so this means that it can be prescribed in primary care after specialist recommendation or specialist initiation. So going to move on to our injectable therapies, namely monoclonal antibodies. This is essentially a diagram to illustrate very simplistically the inflammatory cascade that is involved in asthma. This inflammatory cascade has been utilised to target specific parts of the pathway to dampen down the inflammatory process. If we move to the next slide, hopefully you can see these various areas highlighted in red. The monoclonal antibodies that we use at Nottingham University Hospitals for paediatric patients are targeting the areas highlighted there. And I have got a summary table, but I'm actually going to keep this slide showing for now, just because I feel it quite accurately depicts the parts of the pathway that these injectables are working on. So omalizumab, mepolizumab and dupilumab are all licensed for use in children over 6 years old. If we break this down and start with omalizumab first, which is towards the right hand of the screen, it's for the treatment of severe allergic asthma, and it works by binding to free IgE, which will then lower the amount of free IgE in the blood. And then this will stop IgE binding to receptors on mast cells and basophils, and then will hence block the IgE mediated secretion of inflammatory markers from these cells. Mepolizumab, which I've highlighted towards the bottom of the slide, is for the treatment of severe eosinophilic or type 2 asthma and will prevent IL-5 from binding to and subsequently activating IL-5R+ cells. This will then in turn reduce the amount of circulating blood eosinophils that are present. Dupilumab, which is at the top of the slide, is for the treatment again of severe eosinophilic asthma or type 2 asthma, and is directed against IL-4R alpha, which will inhibit signalling of IL-4 and IL-13, and these both play a central role in inducing inflammatory processes that are seen in allergic rhinitis, asthma, and atopic dermatitis. So dupilumab is actually also an agent that is used by some of our dermatology colleagues as well. Tezepelumab, which is towards the left of the screen, is licensed for use in young adults aged over 12 for the treatment of severe asthma, where other monoclonal antibodies have either not been tolerated or where we've got patients that aren't eligible for the other monoclonal antibodies. Tezepelumab will target something known as TSLP, otherwise known as thymic stromal lymphopoietin, and this essentially is at the top of the inflammatory cascade and will reduce the release of downstream mediators that are involved in the inflammatory processes in asthma, including eosinophils, IgE, IL-5 and IL-13. We've started the majority of eligible patients on monoclonal antibodies on an outpatient basis, and most of these do actually receive their treatment via a home care service. And I think for us as a team, the catalyst for setting up the home care services and really developing those was the COVID pandemic, because we were ultimately trying to think of ways of minimising trips to the hospital for patients and their families. Obviously, setting up this process was heavily supported by and led by the nurse specialists, one of whom is Debra, who I'll be handing over to in a moment, and they facilitated training and telephone support as needed for these families. So that was the table that I mentioned, but hopefully we've covered everything when we've been talking through the illustration of the inflammatory cascades. So I'm just going to talk through very briefly about MART licensing. So MART is obviously maintenance and reliever therapy. And I wanted to mention that there is a Nottinghamshire APC document that will list all the licensing and inhalers available for MART therapy for adults, young people and children over 5 years. All patients that are receiving MART therapy should have a personalised asthma action plan, but I'll let Debra talk about this in a bit more detail in a few minutes. The clinical studies, which were the basis for MART licensing, were carried out using dry powder inhalers, and so they are generally the main inhaler devices used. But whilst we're talking about dry powder inhalers, they are more environmentally friendly when comparing them to their counterpart MDI devices. It is worth noting, though, that there are some MDIs or metered dose inhalers that can be used and do have a license for MART. So the basis of MART therapy is to use an inhaled corticosteroid in combination with formoterol. And the reason why we use formoterol is when we're thinking about that long-acting beta agonist component, we want it to be having a rapid onset of action, because our MART inhaler is also going to be used as reliever therapy. So when we look at formoterol as an agent, it has an onset of action of roughly 2 to 3 minutes. And if we compare this to another long-acting beta agonist, such as salmeterol, which is what you'd commonly find in our serotype inhalers, that actually has an onset of action of roughly 10 to 15 minutes, which just wouldn't be particularly effective if you were using a serotype inhaler as a MART device. So it's for this reason that in ICSs in combination with formoterol can be used for MART therapy. And then my final slide before I hand over to Debra is just to mention that there is no licensed MART dose or inhaler for children under 12, but NICE and GINA do recommend using MART for under 12s, but obviously this would be in an off-label capacity. GINA and NICE both mention that in 6 to 11-year-old patients, you can consider very low dose ICS in combination with formoterol and step this up as needed up to low dose ICS and formoterol. But what does this actually translate to in terms of inhaler devices? So your very low dose ICS in combination with formoterols would commonly be the Symbicort 106 turbohaler or your Symbicort 103 metered dose inhaler. And I've just added a note to the slide that if we're using the Symbicort MDI, this can only be connected to an aero chamber and doesn't actually connect to a volumetric spacer device. And then just to complete the cycle, your low dose ICS formoterol, we'd be looking at using the Symbicort 206 turbohaler. So at this point, I'm going to hand over to Debra, who will be discussing asthma action plans, and we'll go through a case study as well.
Okay, so it's very clear that asthma action plans are an important part of management to help people control asthma. That's for children and adults. And asthma action plans should be clear and simple. They should be individualised, and traffic light systems seem to be the way to go. And certainly when you look at different areas, most areas do use a traffic light system. So what I'd like to show you is the the asthma action plan that we use and sort of talk about why we use it. The most important thing is that on all of our asthma action plans, at the top, it says during an asthma attack, immediate use of salbutamol or Ventolin, your blue inhaler, is necessary, but using it frequently means that your child needs urgent help and advice from an adult. We know that it can reduce its effectiveness over time, and therefore it can be harmful. And what we don't want people to be in a situation that they are relying on their blue inhaler so much that when they need to use it, it doesn't work as well. So our messages with asthma have changed significantly. So this is a asthma action plan that we would use. And for example, here you can see in the green zone, it's just about the controller inhaler. So even our terminology has changed. So rather than saying calling a steroid inhaler a preventer inhaler, we are now calling it a control inhaler because you can't prevent asthma, but you definitely can control it. And in this section, when you're in the green zone, you give your controller inhaler, we fill the amount of puffs and the name of the controller inhaler, even mention the colour, and we say that the child should not need and should not be using their blue inhaler at all, so it's controlled. When they're not so well, so they're wheezing, coughing and finding it hard to breathe, as I say, these asthma action plans have been updated over time, and even changing the order of these symptoms has been done, and wheezing, we're talking about the most important symptom. And we would say that they can have 2 puffs of the reliever inhaler, say salbutamol through the spacer. This can be given every 4 hours, up to 6 times in 24 hours. Keep on giving the controller. So we're really saying that this is an important inhaler. And we're also saying in this zone that if the child's symptoms don't improve, within 48 hours, see your GP. So we don't want people to keep giving their blue inhaler without seeking medical advice. And again, reducing the dose of the reliever as symptoms allow. And if the reliever inhaler is not lasting 4 hours, they're in the red zone. And this would be that they're having a proper asthma attack. So they're very distressed by wheezing, coughing and breathless. The child might not be able to talk in full sentences or drink without being breathless. And the blue inhaler is not lasting 4 hours. That's 2 puffs. And so in this zone, we're saying 6 to 10 puffs of the blue inhaler, salbutamol through the spacer. We know that this is as effective as a nebulizer that you'd have in hospital, and it should last 4 hours. And obviously you need to get a medical review. So again, over the years, we might have said you can give this every 4 hours, but now we're saying after one lot of 6 to 10 puffs of salbutamol, they must be seen, but get a medical review. We still have on these plans, if the increased inhaler is not working and you're getting medical advice straight away, say NHS 111 or even sooner, they might be asked to repeat the dose, but you keep giving the controller inhaler morning and evening. And we're talking about if you have to call 999 as well. So the feedback from patients over the years and parents have been that these have been very, very clear. We're now also trying, certainly from the respiratory clinics, to send a copy of these to primary care too. And I'll just go through a MART one. So again, on the top of the plan, it says the same thing about using the blue inhaler. And this one in the green zone, the child must take however many twists of their controller inhaler, and we put the dose in as well. As I say, of what we're using, again, the colour of the turbohaler, and again, they shouldn't be using any reliever inhaler. And if they are not so well, so they're wheezing, they're coughing, they're finding it hard to breathe, they can take 1 extra twist. Usually we say this, they can have up to 4 extra in 24 hours, not including the morning and evening dose, but obviously it depends on the age of the child. But it's very clear that if the extra twists are given in a short space of time or again, the symptoms don't improve, they need to seek medical advice. And again, sometimes we would say 48 hours. Occasionally, we would say even less than that. They are really individualised, these plans. Reduce the frequency of the Symbicort as the symptoms improve. But if the Symbicort is not working, they are moving on to the red zone, which means that they are having a proper asthma attack. Again, very distressed by their symptoms, not able to talk in full sentences or drink without being breathless. We're also making sure that children let an adult know straight away if they're experiencing those symptoms. And again, that's from our experience. We have heard of cases where children are using their reliever inhaler at night without telling their parents, and we don't like that at all. So again, 6 to 10 puffs of the blue inhaler through the spacer and seeking medical review. And that's really, really important. So let's go on to the next one. How do I move this on?
Yeah, click them.
Yeah. So the other thing that I am passionate about is correct inhaler technique. There is no point in being prescribed an inhaler if you are not using it correctly. And as we all know, every single time we see somebody with asthma, and certainly having a review for children, we need to check their inhaler technique and make sure that they are doing it correctly. We also know that inhaler technique, it does fall off a little bit sometimes. So what's really important as well at the top, I've just put that there are 3-minute inhaler technique videos on Asthma and Lung UK, but also there are other like Right Breathe, I think it is, which is really good as well. So again, we have this on the back of our asthma action plans, and Tier 1 training. We point to Tier 1 training for parents and carers as well on the back of our asthma action plans. Still, after all these years, we still get people who do not shake aerosols before each puff. So we are very clear that you need to shake it to mix the medicine and the propellant up together. And if you don't, you may get the wrong dose. So it's really, really important to shake between each puff. And obviously aerosols should be given through a spacer, because 75% of adults do not use aerosols, MDIs, correctly. So if you are wheezing, coughing and breathless and don't feel like you know where your very next breath is coming from, how can you take that MDI correctly? You can't. So use of a spacer is really, really important. Large volume spacers or aerosols or aero chambers are absolutely fine. Also, with aero chambers, it's really, really important that they use the correct one. The yellow aero chamber with a mask, I think I have one to show you. So let's see if you can see that. So this is actually up to the age of 5 and no more. In schools, when we do school visits, we are still finding children of 10 years old using a yellow aero chamber with a mask. Whereas the blue aero chamber with the mouthpiece is so much better if they can't use a dry powdered inhaler. So again, dry powdered inhalers, you inhale fast and deep to break up the particles to carry it into the lungs. And it's really important to hold your breath afterwards as well for up to about 10 seconds. I'm not going to go through all the inhaler technique here because I'm not very good at doing it on camera, face to face. I'd be telling you a lot more, but it's really important to get correct inhaler technique. And now I'd just like to go through a bit of a case study, which is really interesting. So they were referred to the respiratory clinic, and they had very frequent severe multi-trigger wheeze, probable asthma. And I just wanted to let you know, 13 respiratory admissions to hospital, 7 in 2020, 6 in 2021, in intensive care, PICU, high dependency, 4 admissions in 2020, In 2021, 1 admission to high dependency, and her admission length was between 2 and 6 days, so quite a lot really. And when she first came to us, she was on salbutamol alone. As I say, in October 2020, she was referred to the respiratory team, and we started her. We gave her Seretide, 50 micrograms, 1 puff BT via MDI and spacer, and started azithromycin as well. And then in December, we started her on MART using Flutiform, 50 micrograms, 1 puff twice a day, and 1 puff up to 4 times in 24 hours. Azithromycin, theophylline syrup as well. And as Anneka has alluded to, blood tests were necessary to make sure the theophylline was the right dose. We started Montelukast in March 2021, and then in July 2021 we stopped theophylline. And I just wanted to give you another quick update. So azithromycin and Montelukast was stopped in August 2024. Flutiform was changed to Symbicort MDI 100/3, 1 puff twice daily by the aero chamber, plus 1 puff up to 4 times extra MART if needed. And she now has had no admissions for 3 years and 7 months. So it works, but that was obviously completely off license, but it made a huge difference to her quality of life, to her parents' quality of life, to the family quality of life, and to her future as well. So I would like to now hand over to Kay, if that's okay.
Deborah,
is that right, Gemma?
Yeah, just before you hand over there are just a few questions for you and Anneka. Would you mind if I just quickly go through them before we moved on to the next section?
Yeah, that's fine.
Yeah, there was just a couple in there, and Dr. Yanney very kindly answered one of the questions. But there was there was a question re PSD, so it's a patient-specific directive that many of us nurses use in practice for certain things that we're obviously administering. I'd advise, obviously, we wouldn't normally use a PSD for Symbicort, but what the question actually is with Symbicort, isn't it 12 years and over that we can do a MART regime at the moment, if I'm correct? So what they're asking is, basically, if we think the child would benefit from a MART, using Symbicort on a MART, but they're under the age of 12, within primary care, would you recommend or encourage the GPs to consider prescribing that, or would it still be under the advice and guidance, obviously, from secondary care?
I think under advice and guidance from secondary care, because we want to make sure that the diagnosis is correct. We want to go through everything again, and yeah, it's. I mean, Jayesh and I have this conversation quite often. I think we've got to get everything correct, and so I think communication as well is really important between primary and secondary care. And in the future, things will change maybe.
I think as long as you make it clear that that's an off-label use, there is no problem in using it in that age group. If you're confident about the diagnosis and you want to use MART, then in the 6 to 12-year age group, it is an off-label thing. Gina and NICE both say that it can be used, so there shouldn't be any problem using it. I think if you struggle to convince about that in primary care, then obviously clearly bounce it back to secondary care. And I think we need to also make a distinction here about the concept that is coming in, which is called AIR, anti-inflammatory reliever therapy, which is the GINA and the BTS guidelines are saying that in people who are newly diagnosed with asthma, and especially in those over 12 years of age, actually for the first 2 steps, you can use the anti-inflammatory reliever therapy, AIR, that is the use of the formoterol and budesonide combination only as required. So in the past, you might have been prescribing salbutamol for these people, which is the incorrect thing to do now. And so you should not confuse the MART with air, but the licensing for both is definite about 12. The 6 to 12-year-olds, air and MART, are both off-label. There are more research studies planned, and you might get a firmer recommendation in the next iteration of guidelines, but you are still allowed to use it, and as long as you clarify that it's off-label.
Lovely. And the next question in a chat was, what is the minimum age for salbutamol nebulizers and inhalers?
I'll cover that in my talk.
Oh, lovely. And then they've put, although DPI is environmentally friendly, is MDI more effective than a DPI?
Not really, I think, and obviously both of them, they need to be done with the right technique, but it's not that one is more effective than the other. I think we often ask the young person or the patient to choose the device rather than choosing the molecule. Saying that, I think during an acute attack, for anybody, even if they have perfect technique with the DPI, they might not be able to use, I mean, you shouldn't be using the PMDI on its own, full stop. In the people we are talking about, the Paediatrics, you should never use PMDI on its own. So even in somebody who can competently use a dry powder inhaler, you may need to give them a spacer with a PMDI for an acute episode, but not carry on using the salbutamol frequently.
Lovely. And then the next question was regarding prescribing MART. So in general practice, obviously, if a patient is on a MART regime, we normally remove the salbutamol from the repeats and obviously don't give it routinely. But obviously within the asthma action plan for those having an attack, is still recommended SABA use. So they're just saying, should we still be given a blue inhaler, a SABA, just for those emergency situations, even if they're on MART?
So I think as long as you stay within the guideline recommended doses, so which is less than 2 blue inhalers per year, less than 2 per year is not a mistake. I'm saying it again, less than 2 per year. Then I think you got to remember the real evidence and effectiveness of salbutamol use in the acute episode is within the first hour. So I think, as Debra was saying on the management plans, that they have that first dose, and then they they get seen, they go to the hospital, they go to emergency department, they go to wherever. Okay, so the important point is, do not overdo it and don't give out more than 2 per year.
Okay, lovely. Thank you very much. Thank you, Debra.
Gemma, I just think as well, the case study really illustrated, and we do have this experience, that people on MART do not generally use a lot of blue salbutamol. Yeah. They just don't.
Yeah. Obviously in primary care, we're encouraged massively to, promote them not to reach for the blue, to almost pretend they don't have it. They use their other inhaler. Yeah. But obviously we're just mindful now. I think most of us practice nurses here are just trying to make sure that we're not telling people not to have something maybe they may need. So that's why I think we were checking. So I'm so sorry, Kay. We'll hand back over to you. I do apologise for interrupting before you start.
That's fine. Have I still got 10 minutes though? Am I okay to?
Yes, yes, very much.
Okay, good. Right. Let me just share my slides. Okay, so I'm Kay. I work in the public health team at Nottinghamshire County Council, and my areas of interest are tobacco and vaping, and I particularly focus on protecting people from secondhand smoke and prevention and engagement work with children and young people. And it's that I'm really going to talk about today in respect to vaping, to describe to you what we know about vaping in young people and what we're doing about it in response, and also what you can do to support the work. So we always start in public health, we're looking at the evidence for a situation, which is based on the data and the facts. And contrary to what you might think from reading the news, most young people neither vape nor smoke. A large majority of young people have never even tried vaping, but you needn't take my word for it. So I'm going to show you some actual data on the next few slides. So this is the first slide, and it shows the results from annual surveys of young people, which have been undertaken by the national charity ASH. They contract YouGov to do the surveys using standard survey methodology. and it shows the trends in vaping over time in the cohort aged 11 to 17. So what it really shows us is that vaping fell slightly during the pandemic, and it increased quite rapidly, but now it looks like it might be starting to decline again. And you can see that the proportion of children who say they smoke is much lower than those that say they vape, but there has been a recent uptick, which is also not so good. And the other important thing to note is that the ever tried vaping maximum is only a fifth of young people in the 11 to 17 range. Excuse me. So this is the second slide, which shows data from the biannual NHS digital survey on smoking and vaping in 11 to 15-year-olds, so it's not quite the same age cohort. And in this one, the 20% ever tried vaping in 2023 is almost exactly the same as for the ASH survey in the same period. And it also confirms to us that more young people are vaping than are smoking, and smoking is continuing to decline. But there has been quite a rapid escalation in vaping, and that's what's driving concern about young people's vaping. But still, most young people don't vape or smoke. And then this is the third slide. So we had the national data, but we were interested in what was happening locally here in Nottinghamshire. So we did some local survey work in Not Schools, and this slide shows the results from the information that we received in 2023 and 24. So it's really current data from an anonymous survey of actual NOTS children. And it's about 4.5% of the 11 to 15-year-old age cohort in Nottinghamshire County. And you can see there that 76% of the children who replied said they'd never even tried vaping. And of the 24% who said that they had tried it, about half of that group had only tried it once or twice. And only 5% said that they vaped regularly. So this all shows us that actually vaping isn't the majority activity that you might think from what you read in the press. It also shows us, which I haven't put in the slides, that there is an age gradient in vaping, that the problem is mainly concentrated in young people aged 15 to 17, and that shows us where we need to target our activities in trying to address this and prevent young people from starting to vape without driving them to smoking, which is very important. So what can we do locally? In the public health team where I work, we have a lot of work going on with schools and with the youth service to try and prevent smoking and vaping in young people. But we do want all the other partners across the wider system to join in our efforts in a consistent approach. So we are asking for your help to do this. And the first thing we want to do is to provide fact-based, consistent messaging on vaping, which is in line with national public health guidance, with NICE guidance, and with what the Chief Medical Officer has said. And these messages on this slide are the messages that have been agreed between local partners for us to use consistently with young people. We do try and promote the fact that most young people don't smoke or vape because social norms are really powerful in influencing the behaviours of young people. I'm going to make sure that these slides are circulated to you afterwards, so you'll be able to have a look at those messages in more detail. And there's a link in here for some local conversation guidance that we've developed that gives some more information about talking with young people about vaping, including how to tackle some common myths that are frequently expressed about it. And the second thing that we've done is we've developed quite a lot of local resources which use our agreed messaging. We've got some posters aimed at young people, we've got a postcard with some key facts for taking away, we've got some information that's easy read for young people, and we've got some posters promoting reporting of underage sales. And you can get copies of all of these materials for your setting. The QR code on this slide is to a form where you can put your address and how many of each item you like, and we'll send hard copies to you for you to display and use to provoke conversations with people about vaping. The second thing we advise is that you only signpost young people to reliable sources of information. And we've listed them on this slide, and again those links will be live when we send the slides out to you. Particularly, we recommend that you avoid signposting to non-UK sources of information because these might not be accurate for the UK context. And as an example, a lot of Canadian websites about vaping talk about the use of cannabis, which is not illegal in Canada, but of course it is here. So that information is not relevant for a UK context. And the pictures and the locations and just the general style of the sites that are UK will be designed to resonate with our own young people. So that's another reason to only use the UK sources of information when you're signposting or giving people suggestions for where else to look. And the third thing is I'm often asked what people can do if they receive direct information that a person under 18 is vaping. And this slide suggests a set of actions, finding out where they got the vape from if you can, and reporting underage sales to the Citizens Advice Consumer Service, where they'll be forwarded on to the local trading standards team for exploration. And trading standards being an intelligence-led service, they do follow up any reports made to them of underage sales. And this activity helps to create a kind of wider climate inhibiting underage sales and reduces young people's access to the products. And then we suggest you use the very brief advice model, which you're probably all fairly familiar with. It says ask, advise and act. Those 3 steps to have a consistent fact-based conversation using the information that we've provided about the key messaging to guide your conversations, and including the social norm that most young people don't vape. It's possible that young people, when talking about their vaping, will suggest that they're vaping because of their mental health, because there is a widespread misconception that nicotine products help people with their mental health. And the reason for that is because nicotine withdrawal feels like anxiety. So when a person smokes or vapes again, the withdrawal symptoms are being addressed and it makes them feel calmer. So they associate the nicotine with the feeling of calm, but actually the anxiety is probably being exacerbated or produced with nicotine withdrawal in the first place, and the nicotine product isn't a safe or effective or long-lasting way to deal with a mental health issue. So we suggest you could talk to them about that and ask them what other things they could do if they weren't vaping that they think would help them to relax. And you could also signpost the young person to the Childline website, where there are some tips for giving up vaping on it. We do have in the county a pilot project that's going to start in April, actually looking at giving stop vaping support to young people who vape and want to stop. But that is going to only be in a few selected schools because it's just a test and learn approach, because this kind of action is very, very new, hasn't been done much before. But if we get to the point where we roll it out, we'll obviously give more information about that to our partners. So the other thing about vaping is it does need to be handled quite carefully, because vapes are also an effective way for adult smokers to give up smoking. And young people might have family members who smoke. And of course, if a family member gives up smoking and switches to vaping, that will reduce the young person's exposure to secondhand smoke. So it is a desirable outcome for a smoker. I mean, I'm always at pains to emphasise that we're not suggesting that anybody who doesn't already smoke should start to vape. Vaping is a tool for adult smokers to quit smoking, and that's all it is from a public health point of view. And we do recommend in all our services for adult smokers that people shouldn't vape around babies and children, and should be considerate about for others who might be sensitive to vape aerosol, which would include people who have asthma. We're hoping that the regulations on vapes will be strengthened if the Tobacco and Vapes Bill becomes law, which is currently under discussion in Parliament. Maybe you've heard about it. It's mainly about raising the age of sale so that people that are currently 15 and younger won't ever be able to legally buy tobacco products. But there's quite a lot of legislation in there about reducing the appeal of vapes to children and young people by restricting the flavours, for example, and the way that they can be marketed and packaged and sponsored in things like sports. And there's also some new rules on smoke-free spaces, and a separate environmental legislation banning disposable vapes from the 1st of June. And disposable vapes are thought to be one of the things that are driving youth vaping, because they're kind of pocket money priced. So when they're no longer available, vapes will be more expensive, and that will hopefully help to stop some young people vaping as well. So I think that's everything I need to say about vaping. But this last slide just sets out 5 things that I think partners can do, which is kind of the ask, really, that you can give consistent, factually accurate messages. You could display our posters and resources in your settings. you can signpost people to reliable sources for further information. I've given some advice about what to do if you encounter a young vapor. You can promote vaping as a stop smoking tool only for adult smokers. And if you have a chance to support the Tobacco and Vapes Bill, if anyone asks you for your thoughts or opinions, or there's any consultations or conversations that you can have about it, we're encouraging everybody to do that, because it will make a huge change to the tobacco control landscape in this country. And that's all, apart from you can follow us on Smoke Free NN on Twitter or on LinkedIn to keep up to date with the work of the Notts and Nottingham Smoking and Tobacco Alliance that the County Council is part of. And thanks very much for listening.
Thank you so much, Kay. That was really good. And I've already signed up to get some posters for my practice from your little QR code, so that's really helpful. Dr. Bhatt, do you want us to hand over to you?
So I think a lot of what you heard so far is, do this, do that in asthma, and absolutely the right way to go about. What I'm going to talk about is actually what not to do in asthma. Once I get my slide in a presentation mode. Okay. Let me minimize. Oops. I don't know what I've done. Can you see the sides still, or has it gone away? Oh, it is. Yeah, there you go. What we have heard so far, yes, there are some changes, but a lot of this has been in the making for quite a few years, actually, because the MART treatments, for example, where the first trial was done in 4 to 8-year-olds about 20 years ago. So I think that has been in the coming. But the paradigm shift that I'm going to talk about is really very recent and in the last few years only. So that's what I'm going to talk about. What I'll do is I'll give you some of the background of why this has come about, and illustrate that with some of the evidence, both from the National Reports and Initiative, which has brought this to the forefront, but also the underpinning literature behind that, the research evidence why this has all happened. So just to show you, the emergency admissions and death rates in the UK, and you won't be able to read all the countries on the panel that I'm pointing out with my cursor. They're by different age ranges. So the top is 10 to 24-year-old, and the middle one is 10 to 20 per 100,000 children, and that's sort of overall for that old age group. But you can see that the blue is the UK, and we are not doing very well as compared to almost all other European countries. And this is talking about admissions and death in people with asthma. And then when you look at the outcomes for children and young people who live in the most deprived areas, it's even worse. Okay, so something needed to change. This was brought into specific focus by the NRAD report, which was published in 2014, National Review of Asthma Deaths. So this looked at all the deaths that happened in the UK for people with asthma. And overall, there were 180-ish deaths. But when you looked at children and young people, in that year, 2012, there were 28 young people who died. 10 of them were less than 10 years, and the other 18 were between 10 to 19-year-olds. Some more recent data pre-COVID showed that slightly different age ranges, but for the 15 to 24-year-old there were 22 deaths, and for the 0 to 14-year-old there were 20 deaths. So one death is too many, but still, when you can see from these numbers that the numbers were staggeringly high. And the NRAD report delved into what could be the underlying factors, and especially what avoidable factors we can look at and potentially avoid, as the name suggests. So what they found was that there were deficiencies in the care that people received, and also recognition of the risk that this person might be at the risk of getting a severe attack and a potentially fatal attack, and then what can be done to minimize that risk by avoiding the avoidable factors, both in parts of the families, the patients themselves, if they're young enough to understand, and the environment, whether we can modify that in any way. And I think a large number had received inadequate routine care. Almost a third of them had received inadequate management of the final attack, wherever that happened. And 9 out of 10 had poor adherence to treatment or reviews in whatever setting, primary care, secondary care. And I think frighteningly, it is not that only people who have severe asthma die. I think from the ENRED report, we learned, and it's there in the literature for everyone to look at, that almost half of them, actually, the deaths happen in those people who were considered to have, by professionals, as to have mild to moderate asthma. And also, it's not that children die in the hospital when they have a severe fatal attack. Often, more than 2/3 outside, the deaths happened outside the medical facilities. So it could be at homes, it could be in schools, and actually, I'll come to that later on in the most recent report. And the proportion of deaths outside the medical facilities was even greater in that report. So I think the NRAD report came out with 19 recommendations. And one of the recommendations I flagged up here was that there should be electronic surveillance of prescribing in primary care, and it should alert clinicians to patients who are being prescribed excessive quantities of short-acting beta-2 inhalers, SABA, largely salbutamol, but it could be others like terbutaline as well. And the flip side of that, if they are being prescribed too few preventer inhalers. I think till very recently, only one of the recommendations had been implemented, and that was the ongoing national audit, which is now a continuous one, and it's running on behalf of the RCP. A few years later, in 2021, there was a Healthcare Safety Investigation Board report, essentially saying the same thing as in the recommendations made by the NRAD report, to say, we should be implementing whatever safety recommendations are outstanding from the NRAD report. So I think nudging people to make sure those are implemented. It's not just that there's national reports were coming out. The politicians got involved as well. And in February 2022, there was this all-party parliamentary group report, and you won't be able to read the small print. But I think that the House of Commons, House of Lords, across the political divide, recognize that SABA inhalers and oral corticosteroids are linked with adverse effects if used excessively. And this report, the party parliamentary group recommended that NHS should incorporate MART approaches where appropriate, and SABA reduction should be incentivized. And asthma guidelines that include recognition of SABA overuse and what should be the alternatives. And I think that has now happened. Coming to the use of nebulized salbutamols, nebulized bronchodilators. So I think some of you might have been aware of death of a child that happened in West Midlands. And following that, there was a coroner's inquiry. And in the coroner's report, the learning point 8 stressed that in that particular child who died, who had a diagnosis of asthma, this child was being prescribed nebules of bronchodilators, short-acting bronchodilator for use with the nebulizer. And it was very clear in saying that this course of treatment should only form part of an agreed asthma treatment plan with the child's local hospital. Okay, so you should have an agreement with the secondary care to be able to initiate that. I, in my practice of over 20 years, have never ever prescribed nebulized salbutamol to be used at home. There are real difficulties when you use a nebulizer at home for a bronchodilator, because that's not driven by oxygen, and it actually worsens the VQ mismatch and then causes the problems. This has been recognized for nearly 40 years now. And as part of, after that coroner's report, the MHRA issued this alert, which all of us should have received as health practitioners, that nebulized asthma rescue therapy in children, home nebulizers should only be initiated and then managed only by specialists. Okay, so really you should not be initiating salbutamol nebulizers in primary care where it's not being used with oxygen driven nebulizers and you haven't had a discussion with secondary care. Now, the parents may go and buy the nebulizer machine, the compressor from eBay, but really the nebules, the drug only comes on prescription. So I think we should be mindful of that. I mentioned earlier that the outcomes in the people who come from the more deprived areas are much worse, and this has been recognized as part of the Core 20+ program, which is looking at reducing healthcare inequalities for children and young people in the most vulnerable 20% of the population. And of the 5 conditions which are looked at in asthma, diabetes, epilepsy, oral health, and mental health, clearly in asthma, the focus is on addressing the over-reliance on reliever medications, SABA, and decreasing the number of attacks of asthma, which are quite closely linked, as I will show to you later on. How are we doing, though? I think we still, there is a need for change, and it's slow progress. This was this is from the lay press, but this is just under 2 years ago, where Katie, who was a young person who died in 2021, this was in Scotland, and her mum gave this interview to say asthma is not taken seriously enough. People don't know how to deal with the condition. There needs to be more awareness of what it is, and I think a lot of the focus was also on the excess use of SABA. And we hope that with this education sessions we are raising that awareness. I keep going on and on about it, but I'm not making any apologies because I want to really emphasize this point. But even after that, Katie's mum's tirade in the press in May 23, there was a coroner's regulation 28 report in December 2023, and it's out for everyone to read. William Gray, there was again this young person who died with asthma, and the coroner came up with this conclusion in the report that the use of oral corticosteroids that is insufficient to effectively manage the poorly controlled asthma in a picture of vastly excessive SABA reliever inhaler prescriptions and the ongoing absence of preventer medication. Okay, so something needs to be done, and I think it's really a sad indictment that this coroner section 28 report has been there were 4 previous similar reports, and still in December 2023 the coroner had to come up with this recommendation. So, all this was then sort of looked at in some detail and with a more recent perspective in the National Childhood Mortality Database, where they looked at children who have died because of asthma and anaphylaxis, and they looked at all those children who died between sort of April 2019 to March 23. So I think covering COVID pandemic, where the dynamics of asthma admissions had changed, but also period beyond that, and a lot of this data is which was not clearly included on the previous report, the NRAD report. They also included those children who died before April 2019, but if the child death overview panel had done a review and completed the report after 2019, that these children were also included. And I think that the headline figure in that was that there is still 1 death happening every 4 weeks. So 1 child with asthma is dying every 4 weeks. And this report was published in November 2024. So this is just 3 months ago. Okay. And then it gives a lot of details about, altogether during the time frame, there were sort of 54 children who died. And then it talks about, what were the triggers, what were the avoidable factors, what were the factors that contributed, including the use of SABA. And I'll put this in sort of a table here. It looked at sort of various characteristics, age, gender, ethnicity, where they were from, deprivation, the time of the year, and whether or not these children were born premature. And you can see that, asthma is more common in boys. There were more boys who died, but there were differences in sort of the rates per million, and I think worryingly and to be noted as a sort of point to when we are practicing in a day-to-day basis that Asian and children with Black and mixed ethnicity were overrepresented. The death rates were higher in those as compared to the whites, even though the number of white children with asthma were much greater. And then I think there's an urban-rural divide as well. More deaths in the urban area, maybe road, traffic pollution contributes big time. And I already alluded this to before, but there is the solid numbers from as late as November 2024. So in the most deprived areas, death rates are almost sort of 4 times as high, and clearly higher number of deaths in sort of autumn and spring, maybe related to the pollen count, but lower numbers in summer, and clearly more premature babies were likely to have a diagnosis of asthma and die. One of the things that was also pointed out was that they looked at emergency department attendances and admissions in the year prior to their death, and I think 65% of those children, who had died, they had that admissions, at least once in the year before they died, and 7 of them had attended over 5 times. So these should now be automatic trigger factors for all of us to do something about, and that was the emergency department attendances and hospital admissions as well, where asthma was quoted as the primary reason for their admission. Now, this may reflect the severity of the asthma, then how bad their asthma is, but also how the asthma was being managed or controlled, and whether or not they're taking treatments. It's complex. It's not just that they just have bad or severe asthma. But what we could recognize on the background of this is that, remember, one asthma attack is a risk factor for another, and which may actually be more severe than the previous attack. And therefore, I think every asthma attack should be treated as a significant event, and we should do the maximum to try and identify any preventable factors and optimize care by someone who is trained to do so. Okay, not everybody should be sort of dabbling into this. Now, I've gone on a lot about, excess SABA use, but actually how much is excess SABA use? And I think even if we look at pre-current guideline recommendations, for example, the NICE 27 guidance was recommending that, you're allowed to use up to 3 puffs of salbutamol per week. So, add it up, it amounts to 150 puffs per year. Now, if you look at most of the salbutamol canisters, they have 200 actuations per canister, okay? And if you're then looking at sort of, even, giving out 2 per year, that is the guideline recommended use. So anything which is more than 3 blue inhaler use per year is excess. And then you can grade that as, more than 13 is really too high. And so if you're going back to the NRAD and then the NCMD reports, in the year before children died, the number of excess SABA. So, almost 40% were being prescribed almost 1 blue inhaler a month. And if you look at the childhood mortality database, actually the number is higher. And then you look at the, some of them were given sort of almost 1 blue inhaler per year. That's 4 out of 100 were being given 1 blue inhaler a year, and that also is sort of quite a lot. That more than 87% of these children were being given more than the guideline recommended salbutamol inhalers per year. And the flip side of that is that if you're using too many blue inhalers, then you're not using as many controlled inhalers. And the numbers, you'll have these numbers on the slides, but they are almost a mirror image of. So if you use too much SABA, you're not using as much corticosteroids, and that's been borne out from evidence. The references that I put there in the slide here. So one way of looking at is, and this was a lot of the evidence that I pointed out to is sort of been across the age ranges, but there was one specific piece of work that was done to look at children 5 to 12 years who were at the most risk of having a severe attack, and sort of at risk children with asthma. And this systematic review published in the Thorax looked at one of the most sensitive marker of moderately increased risk was the ratio of controller to total medication. So we often request colleagues in primary care to send us a list of all the inhalers that have been prescribed. And if you found that there were 4 beclomethasone inhalers given out, but there were 12 altogether, so 8 SABA, so that the ratio of the controller to total inhalers was less than 5, and this child is at the risk of significant exacerbations and hospitalization. So if we look at the data in our patch, so this is sort of, the Nottinghamshire ICB, and you can see that, and this was, I think, data from 2019, which looked at number of children who were being given more than 3 SABA inhalers. And you can see that across different patches is sort of, between a quarter to a third, overall 27%. And bear these figures in mind, we'll come and talk about it later on. And all this, the SABA use in the past has been promoted because, it seems to give immediate relief. So therefore, it was, most widely used treatment for asthma worldwide. And then somebody said that, that over-reliance is actually was considered to be a larger pandemic than COVID. And this is dating back to almost 50 years when we all thought that asthma was a disease of bronchoconstriction and therefore you treat it by bronchodilation. And then we gave the patients the impression that, if your asthma has got worse, you need more bronchodilation, therefore you use the SABA, and that then sort of set up a vicious cycle. That was also being promoted by treatment guidelines in the past, which now obviously has been rectified. But also in those old guidelines, there was this paradoxical message, because we were saying on step 1, you use the SABA, and then suddenly if you're using more than 3 times a week, because most people started doing that anyway, then you switch on to not doing that and go on to a regular maintenance treatment. So there was that paradoxical message confusing everyone. Not only that guidelines were recommending that, but there were some healthcare systems in place, not in the UK, but outside. For example, that in Australia, you could buy salbutamol over the counter. That should never be allowed to happen. In the UK, we had systems of repeat prescriptions where families could click on salbutamol and request that. That again is now moving because we are alerting clinicians to excess SABA use. And all of this is not actually in the SABA use is not evidence-based. And as Anneka has already pointed out, that over time it becomes less effective. And the pharmacological basis why there is beta-2 receptor downregulation. So I won't go into more detail here. And there are so many side effects and downsides of excess SABA use. It leads to worsening of the asthma control, loss of bronchoprotection and the bronchodilator response, and actually then over time causes paradoxical bronchospasm. There is a lot of evidence of that. It enhances exercise-induced bronchoconstriction. It may enhance inflammation and promote pro-inflammatory pathways. And overuse, and I'll show you more evidence of that, is associated with increased risk of exacerbations, and excess use is actually associated with mortality, and I'll give you the evidence of that. And all this, probably also was compounded by the fact that a lot of us clinicians thought of asthma, sort of acute attacks, as they're treated as if it was short-lived inconvenience rather than a red flag to do something different in a chronic disease. And you should not be looking at asthma exacerbations as sort of a series of acute isolated episodes, but take that as a trigger to do something more to improve control and reduce the likelihood of exacerbations going forward. And this has been known for such a long time, even sort of more than 20 years ago, there was this paper which looked at excess SABA use, and it talked about a dose, specific dose, 20,000 micrograms, which is 200 doses of which is 1 canister. So I think once you get to beyond a certain point, there's a sharp step in increase in asthma deaths per 100,000 population. So there are multiple references, and you can go and read them when I send you the slides if you want to know more about SABA side effects. So that led to then this promotion of the program across the world, SABINA, short-acting beta-2 agonist in asthma. These are sort of a series of large real-world population-based studies which looked at trends of SABA and ICS use across the world. And SABINA 1 was a retrospective database study in UK. SABINA 2 was 7 other countries, including Canada and other European countries. SABINA 3 was 25 countries worldwide, but not including US. And the core inclusion criteria was that you should be more than 12 years of age and have a current asthma diagnosis. And as you can see that, you know, in the one that I've highlighted in this oval shape is UK, and the different colors of the bar include the, you know, the SABA canisters per year. So 0 to 2 is the guideline recommended use, and all other colors in an increasing gradation are number of SABA inhalers. So the yellow is sort of 13 per year, which is just too much. And across age ranges, across severity, including in children more than 6 years of age, you know, a significant proportion are being exposed to a lot of SABA inhalers, on an average 4.1. You know, yes, this is slightly old data, and we hope that going forward this will change. You're looking at in a slightly different way, in a geographical way, you can see that UK is overrepresented with, you know, sort of more than, you know, 4 out of 10 to almost half of the people are being given more than 3 SABA canisters per year. And there is also a strong relationship between prescribing that, you know, to be precise, more than 2.7 per year, and a 20% higher incidence of severe exacerbations. Now, often, you know, people have this debate as to, you know, they are using so much SABA because their asthma is bad. And I think, without entering into that debate, which I alluded to earlier, to say that, you know, even if, you know, it should be a trigger to say we need to look at the control and improve that, rather than carry on doing the same, as in giving them the SABA inhalers. Okay, so without going into the debate of whether it is the consequence of their asthma being the bad and excess SABA causes all these problems, or it's the cause, you know, we don't need to go into the debate. What you should recognize is that there is this strong association, even though it may not be causal in itself. So these are now the specific, you know, conclusions from the SABINA studies. You know, so this looked at, you know, if you, whatever step you look at, whether it's mild, moderate, or severe asthma, whichever step of GINA guidance, step 1, 2, 3, and 4, across each step there is a greater likelihood of asthma exacerbation when you're seeing excess SABA use. Not only exacerbations, but also mortality, more so in those people who were prescribed, you know, excess SABA. You know, in this one, it was looked at as more than 11 canisters per year. When we looked at SABINA 3, which was a overall study in 25 different countries, and people could argue that, you know, different healthcare systems, you know, Russia, China, India, South Africa, where the approach to healthcare is different to what it is in the UK. The availability of medications is different. The prescriptions patterns may be different. So very different healthcare systems, but the conclusions are very similar. That, you know, and across, you know, the number of canisters of SABA that were being prescribed, you know, greater likelihood of severe asthma exacerbations and poor asthma control. Now, if you remember, I mentioned that you know, the US has not been part of these studies, though it is part of the SABINA 4, which will be, you know, the results will be available at some point in the future. But if you look at, you know, data from the US before the SABINA studies, it's also saying the same thing. You know, whether you look at Medicaid, which is sort of the, you know, poor cousin of NHS, versus, you know, just private practice, just focus on the blue lines, which are children, and you can see that as the number of SABA canisters per year get higher, that the greater is the likelihood of hospitalization. And it worked out, you know, in this instance, it was 8 to 14% increase in risk of asthma exacerbation. And even in London, and this is children specific, 5 to 7 year old, in a single center, in a study where you looked at greater than 13 prescriptions. This was after the NRAD report, because this paper was published in 2016, where, you know, we had identified that excess SABA use a problem, but that was still ongoing. And then you can see that a very significantly greater risk of hospitalization when you're using too much SABA. Since then, you know, there's the SABINA Junior data has come about, which is, you know, SABA use in children and across different age ranges, you know, 1 to 5 year old. Someone had asked about salbutamol under 1. So I think, you know, that's a different population altogether. But whether you look at the preschool visas, 1 to 5 year old or 6 to 11 year old, or the adolescents, where now you might be treating them as similar to adults. And then, you know, it's going, you know, a substantial number of children were looked at, and it's going at, you know, how many canisters per year. And you can see that, you know, more than guideline recommended 3 to 6 is being prescribed in you know, 36 to 46% of children. And that is associated with a higher future exacerbation event rates across all the cohorts. And they're more likely to have an exacerbation, and they're more likely to have a severe exacerbation as well. Not only that, obviously there are healthcare costs as well, and it has been looked at across Europe, and it is found that the costs are much higher where there is excess SABA use, and this was looked at in children in Sweden as well, where the data was similar, where they found that maybe if you're atopic, then there's a greater risk of being prescribed greater SABA use, but that should not be the case. So the overall conclusion from the Sabina studies was that high SABA use, more than 3 canisters per year, is common across all severities, between sort of 4 in 10 to more than half across various age groups and different countries. And high use was associated with a significantly increased risk of death, exacerbations, and primary care and hospital visits across all severities. And now we've known this for, this data is now for over 10 years. And you can see from that there is a dose dependent increase as well. So the greater number of SABA, the greater is the likelihood of severity and likelihood of exacerbation and severe exacerbations. Therefore, SABA use alone is unsafe, and the things need to change. And this is the paradigm shift. This is the most fundamental change in asthma management that's happened in the last 30 years. And the European Respiratory Society came out with this publication and this tweet in 2019 to say that we should move away from using SABA as a reliever on its own, and this represents the most significant step towards representing and reducing the over-reliance and overuse of SABA. And things are changing. So there are trends emerging. There are now alerts and limits in SABA use, and they should be getting all those electronic alerts, because that has been put in place. Obviously worldwide, there should be, the combination inhaler should be made available at an affordable price, and there should be some national initiatives. And then that's what is now started to happen. The national guideline which just came out has now very clearly, unequivocally stated that SABA alone should not be used in people with a diagnosis of asthma. As part of the national bundle, which came out in a draft form in 2021. We do not expect that the final form to be any different, but across all the 5 themes, which looks at sort of addressing the environmental impacts, early and accurate diagnosis, which Michael talked about earlier, effective preventive medication, which Debra and Anneka went through, management of exacerbations, which in some ways I have spoken about related to SABA, and across severe, and for people with severe asthma, but across all these components, and SABA excess use comes through, because even if you look at the environmental impact, I think if you're using PMDIs, that's got a much greater environmental impact as compared to DPIs, and across all of them, you're talking about minimizing the SABA use. That gets spoken about. Some of you might have attended the Ask About Asthma campaign, that the first week in September, when children go back to school, where there's a higher risk of exacerbations, and I think so. This is this is aimed at everybody, families, children with asthma, but also healthcare professionals, and it gives us sort of the 4 simple messages. Talks about get a written asthma action plan in place. Debra went through in great detail about it. Understand how to use inhalation correctly, and keep checking that at every contact. Okay, schedule an asthma review every year and after every attack, and obviously consider air pollution and its impact on lung health. But across all those themes, you have to look at SABA use and address them appropriately. If you look at the learning packages that are now being sort of mandated for people who are in any way in contact with children with asthma, and that's now available for e-learning for health, and there are sort of 5 different tiers. And the tier doesn't describe what profession you are. I think that is the level of involvement you might have in somebody with who's dealing with asthma. So, for example, if there's there's a pediatric consultant who doesn't do that much asthma, then he might need to do a lower tier of training as compared to say Debra or myself, where we have a lot of involvement in people with asthma. So it's the more involved you are in asthma care, the higher is the level of training you need to do. So I think what we need to be looking at is that continually reassess with the focus that SABA excess use is dangerous and should not be now done, which is actually now backed by national guidelines as well. Because even if you sit on the right track, if you think you're on the right track, you will get run over, and if you just sit there and don't make a change. So I think at every contact, I urge you to look at all the 5 A's. If you do APLS, if you do anything else, people talk about sort of A, B, C, D, E approach. I am telling you about an all A approach. It's every time when you see a child, you should be thinking, is this really asthma? Could there be something else going on as well? For example, the child might have asthma. If they've got a bad cough now, it could be they've developed whooping cough. So think about that. And actually, it could be, it's not asthma even. There might be a completely different diagnosis. We get children referred to with, obliterative bronchiolitis. Michael talked about, the prime protracted vector bronchitis. So it's not even asthma. It might be something else. So an alternative diagnosis. Every contact, think about adverse environment, allergens in the house, air quality, both indoor and outdoor. They might live near a motorway. There's a lot of pollution. There might be wood fire burning stores in there. There might be pets in there. Parents might be smoking. They might be vaping. And sort of, I've taken a bit of liberty here and put in anxiety, but I think it's well known that stress of any form can be a trigger. So identify the trigger and try and address that stress. I've sort of been slightly liberal here in using anxiety, but I think it's stress of any form. And then also look at adherence to treatment. I know concordance is a better term, but adherence both to the device and to the regimen. You said use the spacer, use the blue aero chamber, but then they use the inhaler without the spacer. You say take 1 puff twice daily. You use 1 puff, they use 1 puff once daily. So non-adherence to device, non-adherence to regimen. So go through all the A's at each contact. Inhalatorium is an excellent website that talks about the history of inhaled treatment, and there's some very nice pictures available. Then I'll borrow that from there. As the nebulizers have evolved, and you would be surprised that in the past, asthma cigarettes were a part of the asthma treatment, and people were being prescribed asthma treatments. To now having moved on to some very clever inhaler devices, dry powders, inhalers, combination dry powder inhalers, to smart inhalers with data loggers and then adherence monitoring devices, or even the completely different inhaler, the unique soft mist. So very, very much changed modern types of inhaler devices. So I'm going to end my talk by saying that you can carry on prescribing excess SABA or move on to the new recommendations as we are seeing from the guidelines. And that's my take-home message, that SABA overuse has been a big concern over a very, very long period. And this is because of 50 years of entrenched practice dating back to thinking asthma as a disease of bronchoconstriction. But now that needs to change, and change will take time, but it's already happening. So I think, think about all the A's, check and address good basic practice at each contact, addressing all those issues. And is change happening? So remember, I'd said that I'd given you some local data about across our patch. As you can see that over time, the proportion of it slightly presented slightly differently, but the proportion of children who have prescribed more than 3 SABA inhalers per year and no controller inhaler has significantly decreased across all the patches. You can see that. And the flip side, the number of children, this is now as a number of children who are being prescribed the controller inhalers has increased as compared to what was in the past. You can see the numbers significantly have increased across all the 4 patches in our ICB. So I'll end my talk here, and I'm happy to take any questions.
Thank you, Dr.
I think we've got about 20 minutes. Yeah, we got about 20 minutes before we finish. So there's lots of opportunities and chance for all of you to ask questions to all of us.
Lovely. So again, anybody's welcome to unmute. There is a couple of questions in the chat. And one has said, just allergies can be asthma, e.g. hay fever. Not quite sure.
So if I understood the question right, I think without sort of going into whether it's one's causing the, what you can remember that if you have got allergic rhinitis, there is a very great chance that if you have got consistent symptoms, which Michael spoke about earlier, not isolated cough, but difficulty breathing, chest tightness, wheezing, and a cough, and you got hay fever, and then I think those symptoms are very likely asthma. So in somebody with hay fever, ask about those questions and then, make a diagnosis and treat asthma. And somebody with asthma, they're very likely to have hay fever as well. So optimize the management of the hay fever, and then the asthma control could improve as well. Does that answer the question?
Yeah, it does. She says she's got it. Lovely. There was another question there that says, what help can we offer to children with severe rhinitis, but with no other observed symptoms?
I think it's a bit like going back to asthma as well. I think when you talk about rhinitis, I think you need to first establish what is the cause of the rhinitis. Rhinosinusitis could be allergies, could be, but many other things. Could be primary ciliary dyskinesia, cystic fibrosis, infection. So I think if you're confident of a diagnosis of allergic rhinitis, and that has been backed up by sensitization to inhaled allergens, and remember, it is the perennial allergens, not the seasonal allergens, when you're talking about association with asthma. Clearly, somebody could just have allergic rhinoconjunctivitis to tree and grass pollen, and that can be a trigger for asthma, but that is separate to somebody who's got house dust mite sensitization. But if you got allergic rhinoconjunctivitis, then I think that the stepwise treatments would be an antihistamine plus minus Montelukast, bearing in mind what Anneka said earlier about the downsides of Montelukast, and a nasal corticosteroid spray would be the basic treatment. And then I think if you're not winning and you got evidence of sensitization to some allergens like house dust mite, like grass, then you can refer for immunotherapy.
Lovely, thank you. Another question's come through saying, can we use salbutamol inhalers, stroke nebs for less than 3-month-old patients?
I don't want to monopolize the answers, Anneka. Do you want to come in? I'm happy to answer that, but I can. Okay, so I think you should question why you should be thinking of using it in a 3-month-old. What is your diagnosis? What are you treating? I think if a 3-month-old child in the month of November has got a wheeze and a crackly chest, that's bronchiolitis, and salbutamol has got absolutely no role there. I think I can't ever remember in so many years of practicing as a pediatric respiratory specialist that I've used salbutamol in a 3-month-old. So I would question what are you treating rather than asking the question, should you be treating?
Lovely, thank you. There's no more questions in the chat at the moment. Again, if anybody wishes to just unmute and ask the question directly, please feel free to do so, or you're welcome again to put anything else in the chat. If not, obviously, I want to say thank you to all of the speakers today. All of the sessions were really, really helpful and useful, and we really appreciate you taking the time out to do these sessions for us. So, a huge thank you for that. I believe that you are repeating. Are we repeating the session again in July? If there is, was it July that we agreed?
If that's what you're telling us, Gemma,
I think that, yes, there was a date that you'd all said you could do later on in the summer.
Okay.
So again, it will be on the Training Hub website. But again, if there's any colleagues that you think would benefit from it, or again, if you feel you want to come back and just re-listen, because I do find that because I do these sessions, I do hear some of them repeated, but I always take something new from them. Again, you'd be welcome to sign up for any future events. There's no questions coming through.
Also, we would appreciate.
Thank you.
Yeah, we would appreciate any feedback, not just for us to put it in our portfolios, but I think more importantly, if we do it in July, and if you guys think that there's something else you want covered, then that's why we would want you to tell us that if this is absolutely the right thing you want, or you want something different to be covered, bearing in mind that we can't cover everything in that time we have available.